says it's setting up the meeting for Facebook Live, redirecting. Opening Sarah Mojawad.
We're having a bunch of people joining like right now.
We are, yeah. Okay, and actually it says I'm on Facebook, but we may have to just put the recording up later. We have our recording going right now, and out of respect for everyone's time, because I know some of us have to get back to work, we will get started. I'm Carmen Cavalli. I'm a board member of Physicians for Patient Protection. We're joined here by some of our other board members, as well as members of the press. Thank you all for being here today. Physicians for Patient Protection is a grassroots advocacy organization. Our mission is very simple and straightforward, is to ensure physician-led care for all patients and to promote truth and transparency regarding healthcare credentials. The COVID-19 pandemic has shown us the true importance of physician-led care when dealing with critically ill patients and a novel virus. Today, we've got a group of concerned healthcare professionals who want to discuss some dangerous healthcare trends amidst this pandemic and their impact on patient care. A question and answer session will follow. A reminder, please, that you're all automatically muted. When you enter the room, please remain muted until it's your turn to speak or until you're called upon for a question. Some of you are not currently muted. If you can just check your settings right now and make sure you're muted so we can minimize background noise, that'd be great. We will take questions and comments at the end following our final speaker. We have only a few speakers. Each will talk only about 3 minutes, some less, so not too long. We want to keep it short and sweet. And the Q&A session, there's a chat box that you can use. Please direct your question directly to the host rather than to everyone. Or you can raise your hand at the end and we'll call upon you in order. To kick things off, we have Dr. Diana Bloom. She's a board-certified neurologist with 15 years of clinical experience. She's in private practice in Silicon Valley, California.
Thank you. I am a mother, and like all of us here, at some point, I too have been and will be a patient. COVID-19 tragically underscores the significant disparities in healthcare outcomes for minorities and the poor, because we effectively have a two-tiered medical system in this country. A two-tiered system means that physician-led care will only be available to the privileged, while economically disadvantaged people will be treated largely by nurses, thus widening the gap in morbidity and mortality rates for the disadvantaged. I would like to take us through a brief history of healthcare reform to put in perspective how certain laws have led to the creation of this two-tiered healthcare system. In 1997, Congress passed the Balanced Budget Act, which capped the number of residency training programs for physicians to 1996 levels. Although the U.S. population has grown over 20% since the passing of this law, the cap remains. This has led to a shortage of qualified doctors because completing residency is required before a physician can practice medicine independently. Instead of fixing the bottleneck caused by the Balanced Budget Act, healthcare efficiency experts formulated a new plan to address the foreseeable doctor shortages. The Transformation of Healthcare Through Nursing Initiative. This plan pushed for the expansion in the number of nurses rather than doctors to provide more medical care. Meanwhile, healthcare in America began consolidating. Local hospitals shuttered while small doctor practices were taken over by big hospital systems and healthcare corporations. This only exacerbated the doctor shortages. Fast forward to a decade ago when the Affordable Care Act passed, Congress expanded coverage for medical care, but instead of reversing the physician residency restrictions, it passed a new initiative, the Graduate Nurse Education Demonstration, which allocated $200 million for an even greater expansion of clinical training for nurses. This fueled a surge in online nurse practitioner degree mills, which you will be hearing about today. To summarize, in response to a legislation-created doctor shortage, profit-motivated healthcare efficiency experts saw an opportunity to make money with a bait and switch. They shifted individuals trained in nursing to deliver medical care in lieu of physicians actually trained in medicine. The vast amount of lobbying money behind this cost-cutting push from big hospitals, insurance companies, and healthcare corporations has convinced many in our government that only a cheaper but less qualified workforce can solve our country's growing medical needs. But at what cost? Profits are being prioritized over patient care, and patients are needlessly suffering because our legislators have allowed the almighty lobbying dollar to devalue formal physician education and training. It's not too late to course correct and dismantle this unequal and harmful healthcare model. There are two important actions we need to take today. First, we need decision makers in Congress to remove the federal cap on residencies so that we don't have another 3,000 plus physicians per year sitting on the sidelines, especially during a pandemic. And two, we need to establish the associate physician programs and support the bills that promote them. This would allow graduated medical doctors in need of a residency to work in underserved areas in collaboration with an attending physician. Let's end this dangerous experiment we have all been forced into with no informed consent. If we continue to allow non-physicians to expand their scope of practice through legislation, then the essence of do no harm medicine will be replaced by the profit motive agendas that you are hearing about today and likely experiencing every time you seek medical care. Thank you.
Thank you, Dr. Bloom. Our next speaker is Ms. Rain Toman. She's a third-generation registered nurse with 9 years of clinical experience from Buffalo, New York. Rain, on behalf of PPP, I want to thank you for your courage in speaking out today.
Thank you. I want to start off by saying I'm speaking up despite being bullied and threatened not to tell my story because many in my profession believe it would hurt our cause. There's this idea that nurse practitioners are equal to physicians and that our education prepares us to be on their level. When you attempt to shed light on the truth, you are essentially told to keep your mouth shut because you are speaking negatively or what you are saying will not help your profession. Some nursing organizations have even gone so far as to request reporting of negative comments to their website to help protect the profession. One of my goals by speaking here publicly today is to hopefully inspire other nurses to find the courage to speak up about what is happening to our profession and most importantly, to protect our patients. After working as a registered nurse for 5 years in various settings, with psychiatry being my favorite, I decided to pursue my psychiatric nurse practitioner degree and enrolled in a brand new master's program at a local college that would take 2 years to complete. I was excited to do something I love and to help patients. From the start, I realized that this was not an adequate program in the way it was being taught and how it was being run. There wasn't a psych NP on staff. Instead of the director was a clinical nurse specialist in psychiatry, which is a completely different degree path that has been phased out of nursing. You can't even become one of those anymore. I found myself wondering how the program was even allowed to be accredited. Instead of focusing on coursework that would actually help us diagnose, treat, and manage psychiatric disorders in the real world, I found myself writing useless papers on nursing theorists and taking exams that the test questions came from the test bank that you could purchase with the book. One semester, when some students failed a core course required to sit for the board exams, they were offered a secret extra exam as a student success initiative to help them pass. My courses in advanced psychopharmacology and psychopathophysiology were totally online and consisted of 4 online 25-question open book tests. There were no lectures, no instructions. I learned to just quickly look things up in a book and effortlessly got A's. These were supposed to be the courses that would serve as the basis of knowledge for my ability to accurately diagnose and treat psych disorders. That includes prescribing mind-altering psychotropic medications and highly addictive controlled substances. My degree would also allow me to care for patients across the lifespan, yet there were no requirements or even encouragement that I care for pediatric or geriatric patients during rotations, just to get my hours wherever I could, and there was only one class lecture on each of those patient populations. Even more alarming, when I started my clinical training with a psychiatrist, a medical doctor, it was clear I did not have the foundational knowledge necessary to understand the complexity of common psych drugs on a psych patient's brain, despite receiving those A's. How could I possibly provide high quality, independent, safe care to patients if I was not properly prepared? When I was accepted into a better program elsewhere and they looked at this coursework, they determined the credits were not up to their standards and would not transfer. I was essentially stuck in this program, or I'd have to start completely over and lose tens of thousands of dollars and all that time. I joined various private social media groups comprised of NPs at various stages in their careers, hoping to find guidance from my peers on how to improve what I felt like was a hopeless situation. To my dismay, many colleagues were reporting similar concerns. I discovered that poor NP training programs are all too common, and NPs take to social media to discuss how unprepared they feel or actually ask what to do for real patients. And that this was such a problem, there were groups formed years prior solely to discuss how to change the education for the better, but we're making little to no headway because in fact, it seems like NP programs are on a race to the bottom and care more about quantity than quality. Most programs previously were brick and mortar. They were set up like medical schools. They were on site. Most of the nurses that entered had decades usually of nursing experience and their classes were tiny. They worked one-on-one with an assigned clinical preceptor, sometimes a doctor, that their school found them. But nowadays there's 100% online programs, some with 100% acceptance rates. You can even apply and be accepted on the same day. The websites for these programs look more like you're signing up for a credit card and have little to no information on the actual program. The admission requirements are not standardized. There's no nursing experience required. There's no in-person interviews. There's no entrance exams. And some don't even require you to have a bachelor's degree, which is quite scary to me because how can you become an advanced practice nurse with no prior experience? What's more, these programs also ask students to find their own preceptors instead of assigning one. Students desperately scramble to find anyone who will permit them on site and are even willing to pay for-profit companies to find them a preceptor. As you can imagine, this creates a highly variable experience and the graduates of these programs are underprepared for what lies ahead. There are even students that end up not graduating because they cannot find preceptors. The social media boards are filled with daily posts begging for preceptors and stories of students sitting out semester after semester. They are left feeling helpless and devastated and just continue to work as nurses and pay back their loans for an education they never received. The final straw for me came when I started my clinical hours with a preceptor I found, but my school did not set up my contract with the hospital properly, despite telling me months earlier they had, so I could not continue. I then found out on my own accord that my preceptor was not even approved by my state's education regulations. I could not in good conscience continue at a school that either knew this and was allowing this unethical behavior to happen, or they did not know, and this was yet another example of their incompetence. I was done fighting with the school, and per lawyer's advice, I filed complaints with the Nursing Accreditation Agency, as well as my state's education department last summer. The accreditation agency determined there were no issues, and the education department still has an open investigation, and there has been little to no changes with the program. There is no sense of urgency for nursing to regulate itself. This has been a disheartening experience and created major setbacks, not just for me, but many of my colleagues. I would be a fraudulently licensed NP right now, earning a much higher income had I chose not to accept the substandard education and file complaints. I am deeply concerned about the false narrative that NP organizations and nursing groups are putting out there and that nurses are in such fear to speak out. That NPs are allegedly prepared to work independently from day one with education like this and are equivalent to physicians. This is not true, yet this is fed to us as dogma in the hopes that our lies become our truth. Physicians spend decades on their education and training with rigorous medical and science curriculum and stringent admission criteria that NP education does not have. NP programs were designed to be an abridged clinical path for experienced nurses to go back to school and build off that experience in order to work as a team with physicians, not independently. If NPs are to function independently and provide safe care, the education actually needs programs designed to teach us to do that. I'm speaking out because while I am a nurse and support my nursing colleagues, I'm a patient advocate first and foremost.
Thank you. Thank you, Rain. Wow. Dr. Kendall, moving on to our next speaker, is a board-certified psychiatrist with over 12 years of experience and is currently working in Los Angeles, California.
Physicians take huge risks for speaking out for patient safety. Many have been terminated, threatened from their jobs. Even being at this press conference today poses a huge risk to all of us here, but we feel that the public has a right to know about legislation that's going to affect them. For years, the American Association of Nurse Practitioners has been lobbying to allow nurse practitioners to practice without supervision throughout the many states. Why is that scary? Did you know that an NP degree can be obtained in as little as 18 months online with as little as 500 clinical hours? Compare that to a physician who has gone to medical school and residency with at least 20,000 clinical hours. During the COVID-19 pandemic, the AANP pressured the President of the United States, along with the nation's governors, to loosen restrictions and allow nurse practitioners to practice unsupervised in many states. And in fact, many states did fall to pressure and remove those barriers. But what we saw was that it wasn't that helpful. COVID was very complicated. People were very sick with multi-organ system disease. As we found, NPs lacked the clinical skills to carry out the complex ICU care needed for these patients. And yet, even now, many are still taking advantage of the pandemic to promote a dangerous bill that is currently in the California Senate right now. This bill would allow NPs to practice unsupervised in the state of California. Proponents argue that it would increase access to care and decrease healthcare costs. However, we know that from similar bills that have passed in other states that argument is wrong. Even in those states, NPs still go to urban areas and they can lead to increased healthcare costs. This bill does not ensure that nurse practitioners go into primary care, nor does it ensure that they go to rural areas. We support the healthcare team model, and many of us have worked with wonderful NPs under a physician's supervision. My own father was actually hospitalized 2 years ago for altered mental status for a month. He was discharged with a diagnosis of dementia and sent to a skilled nursing facility for rehab. One day while he was there, the NP walked into the room where my sister was present with my father and announced to him, "You have mad cow disease," based on a test result that had come from the hospital. This naturally sent my family into a panic, and we had visions of my father dying a horrible death. But as it turns out, what that NP failed to understand was that test result had to be placed within a clinical context. And as it turns out, my father actually has Alzheimer's and is still with us here today. As a physician, a mother, and a daughter of aging parents, this bill frightens me. I'm frightened of the medical errors I've seen, and I'm frightened that this may further decrease access to a physician. And I'm also angry. I'm angry that I may be a patient one day in a system where physicians are no longer present. I'm upset that my children may one day be in the hands of someone that does not have the training of a physician. And I'm also sad that I have to worry about the future and well-being of my patients. As a physician, I can advocate for my family. But what about all of the other people who don't have physicians in their families? Who's going to advocate for them? Thank you for your time.
Thank you very much, Dr. Kendall. Our next speaker is Dr. Natalie Newman. She's no stranger to most of us, I think. She's a board-certified emergency physician who's been practicing for 25 years. She's also a former Army physician who currently works as a traveling MD.
Thank you. Thank you, Dr. Cavalli, and good afternoon, everyone. As some of you may know, approximately 22 states and DC have unsupervised practice in their states. It is important to note that since the unsupervised practice of nurse practitioners in those states, not one regulatory body has followed up to determine if the care touted is what nurse practitioners claimed it would be. How do we know the care being provided is of top quality? We don't. But this is what Jim Wood alludes to, that as a fact that the proof of that care is sufficient. We have red flags in California that are telling us that this is not a good idea to move this bill forward. The California Nurses Association and the Nurses Service Organization, a nursing liability insurance company who insures over 26,000 nurse practitioners in the state of California, published a nurse practitioner claims report in 2017. In summary, since 2011, practice payouts have increased. Diagnosis, medication, and treatment care management allegations accounted for 84.5% of all the closed claims during the period of 2012 to 2016. Additionally, another study by the Controlled Risk Insurance Company, a malpractice insurance company as well, was published in October 2019. It encompassed a 10-year period, included the entire United States between 2008 and 2018. The conclusion, although nurse practitioners as a whole have minimal impact on overall practice exposure, 59% of those cases involved high severity events across all hospital settings. High severity meaning those cases that resulted in death or permanent injury. Of those high severity cases, 79% involved patients in the hospital. Similar to the aforementioned study, the majority of cases involved error in diagnosis. I suspect that neither of these two studies have been reviewed by the legislators in this state who are considering passing this bill. Had they been, it should have raised concern about the push for the unsupervised practice of nurse practitioners. Here's the bottom line. If their intent is to enable the practice of medicine without a medical license, then legislators have not done their due diligence in ferreting out malpractice data on nurse practitioners, which would provide some indication on the safety and competency of their practices on the citizens of this state. It begs the question, what can California residents expect when all safety measures of supervision, which are designed to protect the public, are removed? Additionally, appropriate oversight by the California Board of Nursing cannot be guaranteed in light of the recent audit, which revealed that the Board of Nursing executives falsified data related to complaints regarding nurses and nurse practitioners. Thank you for your time.
Thank you, Dr. Newman. Next, we have Dr. Linda Anagawa. She's a primary care physician, double board certified in internal medicine and obesity medicine. She has over 20 years of clinical experience. Thank you for being here.
Thank you, Dr. Cavalli. I've been a primary care teaching physician. I've always believed in a team-based model of care. Medical students, residents, as well as nurse practitioners are an important part of the team. I've trained and supervised many. Now, supervised, though, is not a rubber stamp. Physician oversight means I have reviewed the history and physical exam findings. I've corrected errors. I've given ongoing feedback to nurse practitioners to make sure that the patient is cared for in an appropriate and in a safe way. Now, this is what I've learned in 20 years. Nurse practitioners can't provide unsupervised care. Serious errors can result when they don't know what they don't know. And I've actually experienced this both as a teaching physician as well as a patient. Some years ago, I underwent a muscle injection procedure in my neck by a nurse practitioner for pain relief. And this was a nurse practitioner that I taught, like many others, so I felt confident. Immediately after this procedure, I was hit with severe difficulty breathing. I couldn't walk across the room. The nurse practitioner's assessment, I was fine and probably having a little bit of what she called procedure anxiety. And that was when I realized, despite my teaching her, she really had no understanding of the complex underlying anatomy and physiology of what was happening. Because I knew, because I was a physician, I got myself to the emergency room. And I was immediately diagnosed with a punctured, collapsed lung by the attending physician there. Without treatment, I could have died. But because of my education, I recognized the warning signs and got the care I needed. What would have happened to a patient who didn't have my medical expertise? So here's my takeaways. Should nurse practitioners be a part of our team-based healthcare? Yes. Are they equivalent to a physician? No. Can nurse practitioners be trained to perform independently and safely like a physician? No, not unless they go to medical school. You know, we talk about care shortages, especially in the time of COVID-19, and closing the provider gap. But this does not close the physician gap. There are no shortcuts in taking care of the lives of human beings. Thank you.
Thank you, Dr. Onagawa. Moving on, we have Dr. Manaz Haider. She's a physician. Yes, she's a physician, a psychiatrist who's double board certified in both adult and child psychiatry. She's been practicing for 12 years.
Considering we're in the midst of a deadly pandemic, you would think that the government and the healthcare industry would be doing whatever they can to support and strengthen the doctor-patient relationship, right? What if I told you the doctor-patient relationship is under attack by corporations and politicians, both of whom stand to lose nothing if they make reckless decisions about your health? They don't have skin in the game of your health. If you look a little closer at how this industry works, you'll see that it's based on billing codes and actually designed to be expensive and very hard to understand. Because the higher the costs, the more dollars the organizations capture. So whether or not you get the complete care you deserve, they get paid either way. They operate by inserting themselves into the doctor-patient relationship, which is supposed to be sacred and supposed to be based on trust in a doctor's ethics and extensive training. Instead of you and your doctor, the administrators get to dictate all of the terms. You deserve all the ethics and training because you are the one that has the most to lose when bad medical decisions are made on your behalf by insurances and hospital administrators. Is this what our healthcare is supposed to look like? Aren't you supposed to be at the center of your medical care? For years, administrators have put limitations in place to deliberately erode this trust for their own benefit. They want to devalue the role of your doctor so that they can take even more control over your health and therefore dollars. Doctors have to undergo decades of intense full-time study of medicine, thousands of hours of specialty training, and pass countless hurdles designed to weed out even the ever so slightly underprepared. Because the stakes are high. It's literally your life. Okay, so the state of California is ensuring that we get the highest standards, right? Well, no. The California Legislative Assembly is currently in the process of actively dismantling your right to the highest standards of care. The very titans of the healthcare industry that gave us the broken system we have now have backed a bill that allows for the independent practice of medicine by non-physicians who have never stepped foot in a medical school, let alone completed the additional and necessary training of an accredited residency program, but they're still calling their education and training equivalent. Conveniently, hospitals and clinics will no longer have to guarantee a doctor's involvement for the care of every patient. You know who has the most to lose from shortcuts in education? You do. If medical school and residency were extra and unnecessary, wouldn't we as the physicians have gotten rid of them ourselves a long time ago? We're the ones who have to do the training. Would we put ourselves through a decade worth of extra training if it was unnecessary? We do it because we know for a fact that patients deserve nothing less, and that the intensity and depth of education, because we know all the dangers of what can go wrong. Well, sometimes that depth of education clashes with billing. But what about access to care in rural and underserved areas? Well, just a few months ago, California added more years of direct physician supervision for the doctors to get independent practice. In one stroke, they vanished thousands of medical residents who until now were working, ironically, in rural areas. So, is this really about access to care? Your government can stop playing bodyguard for corporate interests. Patients can have both access to care and have a physician-led team with the highest level of expertise if the politicians just get out of the way. It doesn't have to be either or. Patients, you have the right to start asking about who's really behind all the limitations in your care. You have the right to ask for a doctor. Your destiny, the destiny of your health, is in your hands. Thank you.
Thank you, Dr. Hyder. We conclude with Dr. Natalie Newman, because who can wrap it up better than Dr. Newman? We'll address your questions following her presentation. Please type them into the chat box directed to the host, or at the end of the meeting, I'll turn it back to a gallery view and you can raise your hand to ask your questions. Thank you, Dr. Newman. Unmute yourself. Let me, yeah.
Thank you. Every doctor in these United States, and I dare say internationally, has that one patient that has resonated with them. I have a couple myself, but there is one particular patient who resonated with me who was actually not my patient. This is Alexis Jamel Okoa Dawkins. Alexis was a 19-year-old honor student in college. Alexis died in 2015 from an undiagnosed pulmonary embolus, a blood clot in her lung. There was a window in which Alexis could have been saved because she survived, because she survived for approximately 11 hours before succumbing to her illness. Alexis is the personification of what can occur when people are not properly educated and trained in the art of medicine or permitted to practice it without appropriate supervision. Excuse me. Alexis did not have to die. She died because of a healthcare system that prioritized profits over patient safety. She died because a medical institution violated state laws and hospital bylaws of medical supervision. She died because a hospital administration hired an individual for a position for which she was neither appropriately trained nor vetted. She died because a certified family nurse practitioner accepted a position for which she was clearly not qualified. She died because my specialty of emergency medicine did not uphold its national standards. Alexis did not have to die. No one questioned the proficiency of the nurse practitioner responsible for Alexis's care. No legislator, no credentialing committee, no medical director or supervising physician, not even the hiring institution. They looked at one factor, whether or not the nurse practitioner was certified. That's it. This is a litmus test that is used ubiquitously throughout the United States to determine if a nurse practitioner should be hired or not. Do you know who did ask about the nurse practitioner's actual qualifications? The attorneys for the Okoa family, to whom I personally spoke. They had the presence of mind to ask one simple question. Was a nurse practitioner qualified to perform the duties for which she was being hired? The answer was an unequivocal no. By then it was too late for Alexis. Alexis is not an anecdote, not to her family, and certainly not to me. And Alexis did not have to die. Education matters. Thank you.
Dr. Newman, could you show us Alexis's photo again? I think some of us missed it when you first showed her picture. Thank you. All right, that concludes our program. If anyone has any questions, please let us know. Nothing in the chat box. Someone wanted to make sure that we don't miss the point that California requires physicians to complete 3 years of residency training before being allowed to work independently. Meanwhile, at the same time, they're promoting nurse practitioners as independent practitioners with no such training and as little as 500 clinical hours of shadowing. So there's a big disconnect